The chapter that I will discuss is Chapter 9, which is Reimbursement for Nurse Practitioner Services. There are 5 major categories of third-party payers according to Bupert 2018. The text lists Medicare, Medicaid, indemnity insurance companies, managed care organizations, and businesses that contract for certain services. Medicare is a federal program administered by the Centers for Medicare and Medicaid Services and administered locally by Medicare administrative contractors. Medicare covers 2 groups: individuals over 65 years old who have enrolled and paid premiums, and disabled individuals who qualify for Social Security disability payments and benefits. According to CMS 2014, Medicare is a health insurance program for people age 65 or older, people under age 65 with certain disabilities, and people of all ages with end-stage renal disease, which is permanent kidney failure requiring dialysis or a kidney transplant. There are 2 different types of Medicare payment arrangements. If a patient who is under Medicare is not enrolled in a managed care organization, Medicare reimburses the patient's healthcare provider on a fee-for-service basis through a local Medicare agency. Alternatively, if a patient is enrolled in a managed care health plan, there is an extra payment step between the payer and the provider. Through this type of payment, it is called a capitated basis. Under a fee schedule, payment for specific healthcare services are paid through Medicare. Examples of health services included in the fee-for-service schedule are office visits, surgery, ear irrigation, suturing of a wound, pap smear, and one of many other thousands of included services. Payment fees depend on complex factors such as current procedural technology, known as CPT, and international classification of diseases, known as ICD codes, the geographic area where services were performed, and certain office and training expenses of the provider, as well as the provider meeting quality measures. Under Medicare, nurse practitioners can be reimbursed at a rate of 85% of the physician fee schedule. Under the fee-for-services schedule, the more services that a nurse practitioner performs, the more money the nurse practitioner will generate. Each procedural code has a relative value assigned to it, known as the Resource-Based Relative Value Scale, also known as RBRVS, enabling the service to be reimbursed on the basis of the resources related to the procedure and not the basis of historical trends. Resource-Based Relative Value Scale contains 3 components that include a practice expense component, a work component, and a malpractice component. All 3 components are adjusted geographically and contain the following formula: the practice expense relative value times practice expense geographical practice cost index plus work relative value times work geographical practice cost index plus malpractice relative value times malpractice geographical cost index, which equals the relative value. After calculation of the formula, the relative value is then multiplied by a single conversion factor to arrive at the geographical specific fee schedule allowable for a given area. Nurse practitioners that wish to provide service to a Medicare patient on a fee-for-service basis must apply to become a Medicare provider. As stated above, nurse practitioners who are practicing independently will only receive 85% of the physician charge for services unless said nurse practitioner is employed by a physician. Then the practice may receive 100% of the allowable charges when the procedure meets Incident 2 rules. Incident 2 is short for Incident 2 Physicians Professional Services. This term is only known to Medicare. The legal definition to the term is services furnished as an integral, although incidental, part of the physician's personal professional services in the course of diagnosis or treatment of an injury or illness. For nurse practitioners to qualify under Incident 2, services to be reimbursed, the services of the non-physician must be rendered in a physician's office and under the physician's direct personal supervision. For example, if a nurse practitioner and a physician work together to provide physician services, the services can be billed under the physician's provider number to get full physician fee. Certain rules must be met under the Incident 2 provision. The rules are the services are commonly rendered without charge or included in the physician's bill. The services are a type commonly furnished in the physician's office or clinic and direct supervision. But direct supervision does not mean the physician must be in the same room as the provider during the services, but in the same office and immediately available. An example that Bupert 2002 describes as an appropriate use of Incident to billing provision is when a physician sees a patient and diagnoses hypertension. The physician then initiates treatment. The physician employs the nurse practitioner. The nurse practitioner conducts the follow-up visits with the patient, monitoring and treating the hypertension over weeks, months, or even years. The physician sees the patient every third visit under the policy adopted by the practice. The nurse practitioner's work may be billed under the physician's provider number, and the practice will receive 100% of the physician fee schedule rate for the services performed by the nurse practitioner. Capitation is known as a fee paid by a managed care organization to a healthcare provider per patient per month for care of a managed care organization member. Capitated fees are primary care vary by patient's age and gender. Physicians and nurse practitioners are paid a set fee per patient per month for services agreed by the contract. A nurse practitioner is paid the same set fee whether the nurse practitioner sees the patient 5 times a month or none at all. The nurse practitioner must apply to the managed care organization provider panel for the ability to provide care. Similar to Medicare, Medicaid is a federal program administered by the states. Medicaid provides coverage to millions of Americans, including eligible low-income adults, children, pregnant women, elderly adults, and people with disabilities. Unlike Medicare, Medicaid pays nurse practitioners 70 to 100% of the fee-for-service rate set by physicians by the state Medicaid agencies, and state law controls the rates. Many states have applied to the federal government for Medicaid waivers. A Medicaid waiver gives permission to a state from CMS to administer Medicaid in ways that differ from the federal laws and regulations, specifically to enroll patients covered by Medicaid and MCOs. Once a state receives a Medicaid waiver, nurse practitioners can expect that most, if not all, patients covered by Medicaid will enroll in the MCO or other managed care plans. An indemnity insurer is an insurance company that pays for medical care of its insured but does not deliver health care. Indemnity insurers pay healthcare providers on a per visit, per procedure basis. Nurse practitioners submit a billing form to the insurance company to be reimbursed for services provided. Fee schedules were once based on the usual and customary, meaning the charge is usual and made to persons having similar medical conditions in the country of the policyholder. In the event a provider charged more than what the insurer considered usual and customary, the insurer only paid the usual and customary rate, and the provider was responsible for collecting the difference from the patient. Today, however, fee schedules are negotiated between the provider and the payer. From this position, the fee schedule may not align with what is considered usual and customary. Unfortunately, a con to indemnity insurers is that those who are uninsured and pay for their own medical bills often are in the unfortunate position of paying a much higher price that insurers and health plans pay. A managed care organization, also known as an MCO, is an insurer that provides both healthcare services and payment for the services. A managed care organization is an umbrella term that is used to include HMOs and other forms of health plans. An HMO is a prepaid comprehensive health system of health benefits that combines the financing and delivery of healthcare services. A nurse practitioner can gain admission to an MCO provider panel, which then comes along with the designation of a primary care provider, a contract for providing care, credentialing, directory listing, and reimbursement. Once designated as a primary care provider, the provider has full responsibility for the patient's primary care, including complying with the MCO's quality, utilization, and patient satisfaction standards, coordinating care with specialists, hospitals, or long-term care facilities, approving or denying referrals for specialty care, and keeping costs as low as possible while maintaining quality, and lastly, providing a system for 24-hour access to care. Let's take a look at how MCOs work. MCOs sell priced healthcare services to their clients. Those clients can be employers, individuals, or government agencies such as state Medicare or Medicaid. The client then signs up for a particular plan and then offers that plan to patients who often share in the cost of the plan. Group model MCOs are by an employer-employee arrangement. Through a group model, the provider pays a set salary in return for taking care of the panel of patients. A practice model contracts with independent providers or group practices for a product line or services. Contracts between the MCO and the practice govern the relationship. Fortunately, there are no barriers to the nurse practitioner who wishes to contract directly with businesses or agencies that need health services. Bupert 2018 gives the following examples for direct contracts. Nurse practitioner contracts directly with a college to provide college health services. Nurse practitioner contracts with a business to provide occupational health services. Or the nurse practitioner contracts with government agencies to provide school-based health services. There are pros to working through contracts with organizations to provide services. Among the pros are ability to negotiate for fees and autonomy in practice. When billing for services rendered through third-party payers, the proper forms must be completed, with certain information included. The forms typically require appropriate diagnostic and procedure codes. The medical record also needs to contain documentation that justifies the bill. The standard billing code is known as CMS 1500 and includes ICD codes, date of services, patient identifying information, as well as provider identifying information. Without the ICD or CPT codes, the form is automatically rejected for payment. In the current times of provider billing, computer software is becoming more mandated and required and will eventually make the paper forms obsolete. In primary care, the most frequently used CPT codes are evaluation and management, also known as E&M services, and cover office and clinic visits, consultations, preventative medicine examinations, and critical care services. There are specific guidelines a nurse practitioner must follow in coding patient visits. First, billable visits must include face-to-face contact between the provider and the patient. As well, each billable visit must be a diagnostic visit identified with an ICD code. Second, if care is provided, it must be distinguished between a new patient and an existing patient, and the proper E&M CPT code must be selected. Third, key components are taking history, examination, and medical decision making. Fourth, medical record documentation must support the level of care billed. If there is underdocumentation, can lead to charges of fraudulent billing, also known as false claims. For every evaluation and management service billed, the medical record documentation must indicate the medical necessity for the visit. Fifth, upcoding is when a provider codes a visit on higher level codes, yet the medical record does not contain documentation to justify the higher level visits. Angeles and Park 2009 discussed coding as an unexplained changes plans make over time in the diagnostic code they assign that make their enrollees appear less healthy than they actually are. Upcoding helps private practitioners by financially inflating the payments that Medicare makes to them. Interestingly, a normal distribution curve of E&M service codes for established patients is a bell-shaped curve. Consistent upcoding can result in an audit by Medicare carrier, fines, criminal prosecution for Medicare fraud, loss of Medicare provider status, and loss of license. Lastly, it is important to bill the CPT codes that align with the patient code documentation. Failing to bill for all billable services can be an unnecessary decrease in revenues of practice. Self-paying patients are a form of reimbursement for the nurse practitioner. Cons of self-paying patients are that providers are usually unable to provide the patient with a comprehensive cost list to services prior to services being provided. This creates a problem with patients bringing enough cash to pay for the bill in total at the time of services rendered. When allowing patients to keep an open balance and make monthly payments, providers find it necessary to establish a relationship with collection agencies. Discussing the pros and cons of reimbursement for the nurse practitioner. For pros, as healthcare reform evolves, nurse practitioners will play key roles in improving health outcomes of diverse populations. The ability for nurse practitioners to bill for services promotes access to care and meets the demand for underserved populations. Allowing reimbursement for nurse practitioner services allows a way of encouraging nurse practitioner involvement in the provisions of primary care. For the cons, some states have not set mandates for specific reimbursement for nurse practitioners as primary care providers. Nurse practitioners receive lower wages and compensation rates and make it hard to sustain a primary care practice. Commercial health plan payment policies often don't recognize nurse practitioners as primary care providers, meaning in some practices, nurse practitioners must bill Instant 2 services under a physician's name. The impact of nursing practice on reimbursement for nurse practitioners enables the nurse practitioner to be able to bill for services rendered, and it contributes to expanding high-quality primary care. Here are my references. Thank you.